the bite initial and final. Initial and final. The bite closed when the bite closed when the habit disappeared and when the functional matrix was reordered. Initial and final. Okay, let's talk about the early vertical unlocking and the lower arch space control. If we talk about these two items, we will talk about utility arch. To talk about utility arch is talk about alignment, intrusion, midline correction, space control, over-treatment, leaf space control, posterior expansion, molar rotation, protrusion and retrusion, modelling extrusion, etc. And once again, we have to refer to three-dimensional unlocking of the malocclusion. That is starting point toward the functional occlusion. Let me share some tips, some clinical tips about this concept. Sorry, when I talk about utility arch, we are talking about arch length control. Okay, now yes. Let me share some clinical tips about this concept. A mixed dentition class 1 with anterior crowding. The ideal stage to make upper expansion with quadratics and alignment with utility arch. First the transverse action and after the upper utility arch with posterior still adjustable section and anterior 90 section. 2 months and this response very easy from here to here, but with expansion of the upper maxilla. Another mixed dentition class 1 female patient with a little upper crowding and upper left lateral crossbar. The same utility arch. And here, 3 months after with initial alignment. After this, I did the only occlusion development monitoring. Nothing else, nothing else, nothing else, nothing else. Okay. Another beautiful 8 years and 9 months female patient with good looks and a smile that shows some kind of occlusal disorders. A class 1 with anterior lobes and remarkable bimaxillar square shape. Head X-rays films, panoramicas, and frontal. There were neither skeletal nor functional noticeable disorders. And I started unlocking, aligning with an upper perform utility arch. The same arch 6 months later. The beginning and 6 months with the same arch. And take a look to this new shape of this square arch to this ovoid or parabol shape. The same way in the lower arch, and already when square 18 upper LG still blue utility with torque in the upper. No? A chili day in Buenos Aires. The upper premolars erupting in a new transverse dimension and a lower arch going toward the potential crowd. So I extracted the second primary molar looking for the natural redistribution of the lower space. This is the goal. Lateral occlusal guides to establishment of a good occlusion. In the upper arch, I had to complete the bonding, and the lower arch especially were redistributed only with the utility arches. Please take a look at the right lower Crespi. I didn't put anything. The day the appliances were removed with a surgical over-treatment concept, a lower 3-to-3 fixture retainer, final pictures, and a month later showing the brussel adjustment, and a year and 7 months later, here she is, and it is her present occlusion. She used an upper night rotation. When we talk about early treatment, we mean, initial and final. When we talk about early treatment, we mean space. In early treatment, we are looking for space permanently. And there are 3 words that we must have in mind. There are supervise, keep out, and regain. Also, we must remember that in development of the occlusion, 2 processes are involved, the dental adjustment and the skeletal adjustment. Here we must point out once again the importance of the 4th dimension in a therapeutic system of possibilities, where we are able not only to intercept, but also anticipate the problem, making slices and using the E-space and preparing the way to receive the permanent teeth. In the transverse sense, handling the quadrilateral expanding with molar rotation, shaping the lateral arms, and making intraoral torque adjustment in the anterior bridge, or in the sagittal sense, with utility arches, leveling, aligning, intruding, and correcting the sagittal relationship this result. When space was lost, we must regain a simple plate with springs, and the space is regained. Very easy. If there is an ectopic eruption and we need a headgear action, we are able to regain the space and lead to a normal eruption of the upper second right premolar. Or perhaps the multifaceted quad helix with a closed posterior loop with unilateral rotation activation. And we'll regain the lost space very easy. Let me present you this 8 and 9 month female patient with a straight profile and dental skeletal class 3, an ectopic first right molar, lack of space for the upper lateral incisor, lower anterior crowding, and macroglossia. Her X-ray record showing the first and second upper molars in a wrong way. Skeletal and dental class 3, and once again a simple appliance into spine, regain space, regain upper second premolar space, and close upper central incisor diastema, preparing the upper lateral spacings. The goals are being met. A compliant patient, a good patient. And you have the complete occlusion in mixed dentition ready to make the skeletal job. Stay with mud from here to here in a few months, and another X-rays records showing a bilateral normal occlusal behavior and an important skeletal improvement, post-mask tracing, and here the comparison with skeletal, dental, and aesthetics improvement. Robert Ricketts, in his book Bioprogressive Technique with Carbugino, Rollbench, and Shuloff, explained the possibilities of space of the lower arch, incisor protrusion, 6 millimeters, posterior expansion, more than 3 millimeters, uprighting of the lower first molar, 4 millimeters, and preserve the space 4 millimeters. So, in a hypothetical clinic case, we will be able to obtain a lot of space, having the possibility to develop a three-dimensional mechanics supported in a therapeutic system of possibilities through the fourth dimension, time. And timing is treatment opportunity. In this is time to proceed, it's time to intercept, to correct, to reorient, to rotate before the establishment of the transeptal fibers. It's time to manage the space, to use the E-space, and also it is time to neutralize the functional metrics. A performance utility arch, incisor rotation, X-ray records, extraction of second decidual lower molars and upper slice, preparing a distal way to class 1 in the upper jaw. Extraction, waiting for the second lower premolars. I didn't have the necessary space, so I decided to use a longer utility arch, already in square 16 LGB blue. And wait, only wait. Here with the cheek protection, I remove and I put a retainer on the incisor to let the cuspids go to the occlusal contact. And the final view. And the comparison. Initial and final. Once again, a new lower arch shape starting for an indirect system of functional matrix reordering. Very easy. The last reason, and surely the consequence of the other reason, is the early establishment of facial aesthetics. If we actually perform an orthodontic treatment based on these 6 parameters, I have no doubt the last one will take place. So, having in mind the presence of different growth types and the orthopedic response to sagittal skeletal occlusion, and also in the transfer sense, we have a lot of therapeutic options at the growing patient stage, looking for the early establishment of facial aesthetics. For example, this 10-year-old female patient with severe functional disorder, labial incompetence due to an important upper protrusion, class 2 first division, with upper and lower narrowness and severe overjet. Her X-ray records and lateral tracing. Having in mind her unfavorable growth tendency and the presence of severe functional disorders, the ideal therapeutic response is a functional appliance, looking for the jaw advancing and a functional matrix reordering. And here, the case a year after with the occlusal and facial improvement. 1 year use of this functional appliance. And here, 2 years treatment with the same clamp activator with a remarkable occlusal and facial improvement. So it is another way, especially for the functional disorder, patients with a bad growing tendency and dolichofacial patient. Initial, a year of treatment and 2 years of treatment. Please take a look for deep change in the profile and the bilateral contact. Or perhaps the 7 and 5-month-year-old male patient with an old man's face due to a skeletal and occlusal class 3 with upper maxilla defect, good arches shape, and the X-ray records and lateral tracing showing a maxilla hypodevelopment. So the response is a orthopedic forward treatment of the upper maxilla. 4 months treatment with posterior anterior max was enough to demonstrate these facial and occlusal changes. It is another profile, and in spite of having to continue working, also you can see a remarkable skeletal improvement. The superimposition with the forward maxillar position and posterior mandible rotation and the profile improvement. Once again, initial and final. Initial and final, take a look to change the profile. And initial and final. Okay. You never make extraction treatment? Yes, I do. When it is the best solution, I haven't that. And if these cases are treated at the stage of final mixed dentition, usually one is able to obtain important aesthetics improvement. The extraction treatment may be a good response to improve the final aesthetic and the facial harmony. Let me present the last 2 cases. Let me present a 10-year-old and 11-month female patient with severe aesthetic problems due to imbalance revealed by bilateral incompetence, a short upper lip, and a vertebral lower lip, and dangerous upper incisor exposure. 3 order spade troubles and a class 2 occlusion with severe crowding, overjet, and overbite. Narrow arches and severe crowded and upper protrusion. Cephalometric tracing showing a short and posterior rotating mandible. The treatment began with in spite of to be for extraction cases, began with expansion appliances. 4 first premolar extraction, segmented appliances, carpal retractors, utility arches, stabilization sections, initial Nance bottom, I do it myself, and a lot of spaces. The use of class 2 elastic to sectional arches, and a good new shape and alignment of the lower arch. And here with the upper retraction utility arch at the beginning, only for the central incisor with different heights to improve the vertical control. If you make, you can make, you must. Finally, the complete arches and her final occlusion and a little class 2 of the right side retainers an aesthetic result, the most important, an early establishment of new aesthetic, a good balance, a good bilabial contact, a good exposition of the chin, the X-rays and phrasing, the comparison, initial and final, the comparison, and the superimpositions, initial and final, initial and final, initial and final. The most important, aesthetic improvement, the most important. The last case shows us the importance of treatment opportunity and the aesthetic changes achieved starting from forced traction decision. A 10 years old and month female patient with an unfavorable vertical growth. So, it is time to remember another of the biggest theories about the difference between philosophy of limitation in front of the philosophy of possibilities. So, in the first case, we surely be able late beginning of the treatment, so we could think that will be impossible to make some changes in the direction of her facial biotype. But working, on the other hand, working on a therapeutic system of possibilities, as I like to say, we have a lot of possibilities to change the growth direction because the patient is growing. So, let me show you this case with this impossibility to close her lips and the unfavorable biotype, and class 1 with the crowded arches. In final mixed dentition, ideal stage, X-ray records and tracing showing the biotype of growth, 1.11 dolichofacial, and so Ricketts bioprogressive mechanic, the Rocky Mountain retractors. I miss it. I miss them, and another patient with a lot of spaces, and I'm waiting for the second premolars. I have a lot of time, and the patient is growing, and the lower arch, the teeth are going forward. Still with the lateral stabilization arches, and waiting for the eruption of the second premolars. And I have in this moment a class 1 to align in a level with other arch, complete arches. So I did it, aligned, meeting, still ideal, and this final results the moment the bracket was removed, and this change and her aesthetics, and the comparison of the initial and the final, when we have a lot of from 1 to 11 dolicho to 0.50. And we'll take a look to change of the profile, sorry. So profile. A year post-treatment control, the occlusion adjustment. And please take a look at the change of the hip profile, initial and final, initial and final, initial and final. A reduction of the lower third, the presence of chin, and a good bilateral contact. Okay, that is, we say that early treatment is a way to improve the final aesthetics. All in all, we have been talking about early treatment. So we have been talking about bioprogressive. We have been talking about correction of malocclusion by stages, of very best present application of teeth movement, of intraoral regulation, of orthopedic changes of skeletal structure and application of general orthopedic factors, of teeth intrusion, of three-plane space control and concept of the three orders throughout treatment, and of physiological centric. So, we have been talking about bioprogressive therapy, that is early treatment, decrease of forces, orthopedic, sectional actions, cortical and coach, intrusion, and all is the decrease of station cases. So, don't miss the opportunity, the treatment opportunity, don't miss the possibility of early orthodontic through the growth utilization. And finally, I would like to make a little conclusion. In conclusion, early treatment is a decision that involves nice and well-disposed patients with reward-answer treatment that is shown from the establishment of a morphofunctional balance that will result in the improvement of the aesthetics and function harmony. Nothing else. Thank you very much. Thank you very much.